All right, let's get right into it. Welcome to Confused Neuron, the explainer, where we are officially ditching those dry, 1,000-page textbooks. Today we are going to aggressively master the pharmacology of allergic rhinitis. I've got my markers ready, and we are going to map this whole thing out on the whiteboard so clearly that it gets permanently etched right into your brain. Seriously, no more falling asleep while studying. Let's go.
So let me ask you a quick question. What is literally the most annoying thing about spring? For millions of people, it isn't the unpredictable rain. It is the absolute, soul-crushing misery of spring allergies. You know the vibe. The constant sniffing, the red eyes, feeling like your head is wrapped in a thick layer of cotton. So who else is going to teach you how to actually defeat this? A dry, endlessly boring 3-hour lecture from that thick blue pharmacology reference book? Oh, give me a break. We are going to tackle this dynamically. We're breaking down exactly what is happening in your body and, more importantly, exactly how we stop it.
Okay, Section 1, the allergic rhinitis menace. I'm rapidly writing these down right now in bright red marker. These are the core symptoms you need to recognize instantly. We've got sneezing, itchy nose and eyes, watery rhinorrhea, which, by the way, is just a fancy medical term for a really runny nose, and finally, nasal congestion. When your patient walks in looking absolutely miserable, totally clutching a box of tissues, and you see these 4 symptoms pop up, you should immediately be thinking allergic rhinitis.
Moving on to Section 2, Pathophysiology, the histamine bomb. Follow along with me as we map out the sequential steps of an allergic attack on the board. Step 1, right here at the top, allergen inhalation. You breathe in pollen, dust, animal dander, whatever it is. Step 2, IgE interaction. This foreign material interacts with mast cells that are already coated with IgE antibodies from some previous exposure. Step 3, mast cell degranulation. Basically, the mast cell just explodes, releasing all its inner contents. And that leads us to Step 4, histamine release. This is the ultimate detonation of the histamine bomb, along with a bunch of other pesky mediators like leukotrienes.
Now look right where I'm drawing this big arrow. This perfectly illustrates the aftermath of that bomb going off. Notice the localized mucosal inflammation popping up right there. That is exactly where the H1 receptors are causing total havoc. The histamine hits those H1 receptors, leading to increased capillary permeability, and that's what causes the fluid leakage and edema. Plus, it triggers smooth muscle contraction in the respiratory tract. So your airways get tighter, your tissues swell up like a balloon, and honestly, you just feel terrible.
So the absolute crucial point here is understanding our true enemy in this story, histamine. Let me write its definition out nice and big. It is a chemical mediator released by mast cells that binds to H1 receptors, causing vasodilation, edema, itching, and bronchoconstriction. Because histamine is the primary culprit driving all these pathological processes, the runny nose, the relentless itching, the swelling, it becomes the absolute #1 target for our pharmacological interventions. All right, Section 3, antihistamines, first versus second generation.
Let's just draw a line straight down the middle of our whiteboard and compare these 2 drug generations side by side. On the left, we have our first-generation agents. Think diphenhydramine and chlorpheniramine. Now, they definitely work, but they cross the blood-brain barrier and cause massive sedation. They also have anticholinergic effects, which basically leaves you with a mouth as dry as a desert and blurred vision. Now, looking at the right side of the board, we have the second-generation agents, cetirizine and loratadine. Think CNL for clear and lucid, because these are heavily preferred and non-sedating. You can actually take them and still study for your pharmacology exams without falling face first onto your keyboard.
But wait, hold on, let me grab my red marker again and draw a massive, flashing caution sign around this next point. Contraindication. Do not, under any circumstances, mix first-generation antihistamines with MAOIs. Monoamine oxidase inhibitors, like phenelzine. Why? Because MAOIs will violently exacerbate the sedative and anticholinergic side effects of those antihistamines. It is a severe drug interaction. Do not fall for this trap on your exams or, more importantly, in the clinic.
Up next, Section 4, corticosteroids, the heavy hitters.
I'm listing these out clearly on the board because these are the absolute most effective medications for treating allergic rhinitis. Period. We're talking about intranasal corticosteroids like fluticasone and budesonide. They have the highest efficacy. And because you are spraying them directly into the target tissue, your nose, systemic absorption is incredibly minimal. So we totally avoid the massive side effects of oral steroids.
Now, they do carry a few local risks like nasal irritation, nosebleeds, and rarely a fungal infection called candidiasis. A quick pro tip for your patients: remind them not to inhale deeply right into their lungs when spraying. The target is the nasal mucosa, not the lungs.
Moving right along to Section 5, decongestants and rebound congestion. Let's write out the exact mechanism here. Alpha adrenergic agonists. We're talking drugs like oxymetazoline and phenylephrine. These guys directly stimulate the alpha receptors on the blood vessels that supply the nasal mucosa. Remember earlier when we said histamine caused vasodilation and swelling? Well, these drugs do the exact opposite. They strongly constrict those dilated arterioles, shrinking the swollen tissues down and drastically reducing airway resistance. They work incredibly fast to clear your nasal passages. Honestly, you use it and you can breathe again instantly. It feels like pure magic. But
Warning, I am circling this like 10 times in bright yellow on the board. Do not use these intranasal decongestants for more than 3 days. If you do, you fall right into a massive pharmacological trap. You risk a very special side effect called rhinitis medicamentosa. This is severe, brutal rebound congestion. Basically, your nose will become completely blocked up again, and you'll literally become dependent on the nasal spray just to breathe normally. Never, ever use them long-term for allergic rhinitis.
Okay, final stretch. Section 6, alternative agents and algorithms.
Let's just rapidly run through these backup alternatives on our board. First up, intranasal cromolyn. This is a mast cell stabilizer. It's totally preventative, meaning you actually have to take it before you meet the allergen, so the mast cell never even has the chance to degranulate. Next, we have montelukast, which is a leukotriene modifier. This is an awesome option if your patient happens to also have asthma. And finally, intranasal ipratropium. This is an anticholinergic that is excellent for drying up a runny nose, or rhinorrhea. But hear me very clearly on this. It will absolutely not fix your nasal congestion.
Okay, we've mapped out the entire board today. We covered the histamine bomb, the H1 blockers, the heavy-hitting steroids, and that sneaky 3-day decongestant trap. So I'm going to leave you with this provocative question to really test your attention. Knowing all these mechanisms and knowing all the traps of pharmacology we just drew out, which specific drug class will you reach for first to treat the underlying inflammation of allergic rhinitis without failing your exams or hurting your patient? Think about the algorithm, visualize this whiteboard in your head, and you'll have the answer completely locked in. Keep studying smart, and I will catch you on the next explainer here at Confused Neuron.